Thanks everybody for coming out today. We really appreciate it. We've put together a full day of opportunities for you to learn from each other and to hear some updates from us. And we even have a speaker from North Carolina to talk to you. So we're really excited. And please just know that if you see any of us from with TenCare on our tags around, just come introduce yourselves and let us know how the program's going for you. We really do want to hear your feedback. So I've got some announcements that I just want to share, and then I also have some learning opportunities that I want to share so that you can mark your calendars for things coming up. So the first thing is to let you know that we have a robust curriculum available on a SharePoint. And if you want access to this, if you don't already have it, you can email Christina Rodich. Her email's up there. And also, these slides were emailed in advance to you, and we can share them afterwards as well. But we encourage you to access this curriculum, share it with your colleagues, because there's a lot of good examples, templates, exercises, all sorts of things that can help you with your transformation journey. There's a HealthLink curriculum for the behavioral health folks, and there's a PCMH curriculum. Anybody, can access it. You just need to contact Christina for that access. Also, we are planning to update this curriculum every quarter. So if you have new resources that you think would be helpful for other groups in the room, if you have other topics that you want us to dive into more and try to find more resources for you, then you can let me know, because I'm kind of managing that right now. My email is up here, carly.campbell@tn.gov. So hope to hear from you on that. All right, another announcement is specifically for our PCMH groups in the room. Many of you have already been in regular contact with Meredith about our NCQA requirements. So as you know, part of this program requires that you obtain or maintain your NCQA recognition. And we've heard from a lot of you that you're well underway with this process. Many of you have already achieved it. But I just want to take this time to remind you of the deadlines that are coming up. So if you are a Wave 1 practice, that means you started with this program in 2017, last year, then your deadline is less than 2 months away. So we're hoping that you have your NCQA recognition by August 12th. And I think Meredith has been in touch with all of you individually. If this is sounding foreign to you, please come find us. But I think you're pretty aware of this. Now for the Wave 2 groups that just started in January of this year, you all have enrolled in QPAS, and the next step is that you need to submit the payment code. And that will actually make sure that your process is paid for by the state. So that's an important step, and that is due by June 30th. So that's, less than 2 weeks away. So if you haven't already done that, then talk to your Navigant coach, and they can help you know where to put that in and how to do it. Once you submit that code, then you'll have 12 months. So 12 months to finish the recognition process. So for the Wave 2 groups, we're requiring that you receive your recognition by June of 2019. So those are just some deadlines to keep on your radar. Okay, another announcement has to do with the care coordination tool. And we at TenCare want to make sure that all the right people have access to the tool. And so when people have moved on from their organization or have left, then they no longer need access to the tool and to all of that identifiable data. So every year you'll be receiving an AUP form, which is an acceptable use policy form, and you'll be asked to sign it, digitally sign it, and that will just make sure that everybody who has access has been recognizing the security process each year. So this has already been emailed out. Many of you have already signed it, and we appreciate that. If you don't sign it, then your access to the care coordination tool will be revoked. But of course, we can get you access again. You just need to sign this form. So the email should have come from the security.aup forms at TenCare@tn.gov. So make sure to look for that email if you haven't signed it already, and we'll be asking you to do this once a year. All right, so this announcement has to do with some surveys that are coming out. So I know we ask you guys to do surveys a lot, and I want you to know that we actually really care about the responses. We really read them, we evaluate them, and share them with some of our stakeholders. So it really does help us to evaluate and improve the program. And this particular survey is going to be very similar to one we asked you to do around this time last year. So we're kind of looking to compare how was your experience last year? How is your experience this year? What has changed? And those will be emailed out in the next 2 weeks. And we'll just be asking you for your feedback on various aspects of the program. And feel free to write in the comments any suggestions that you have, or things that you think have been working really well. So appreciate that, and also share that with your colleagues as well. All right, so those were the announcements, and now we have some learning opportunities coming up. Obviously, you're here today to learn, and we appreciate you being here. And we're going to continue to offer you opportunities like this one throughout the next few months. So one of those is training from Dylan and Debbie on how to use the care coordination tool. So Dylan and Debbie are here today with us, and you can find them anytime today if you haven't already taken advantage of their services. They will come to your office, come to your practice, and work with you on how to best incorporate the care coordination tool into your daily workflow and how to make it make sense and support your transformation. If they've already come out, you can schedule them to come out again if you need a refresher. And we hope that you do take advantage of that. So if you want to sign up for some extra help with the care coordination tool, you can find them today. They will have some sign-up sheets for you to come out and work with your schedule. Or you can follow this link and sign up online. And like I said, these slides have been sent out, so that'll probably be one way to follow that link. So another opportunity to learn is a webinar series that is hosted this summer. Sorry that the text is small, but I will tell you that basically each month, starting this month, there's a different topic. And these webinars are hosted by our health plans. So AmeriGroup, Blue Care, and United have gotten together to put together this content specifically for you all. And the first topic is all about HEDIS 101. We've already had the first webinar, but if you didn't attend that, it's available this Friday and next Tuesday. This Friday, it's at noon, and next Tuesday, it's at 3 p.m. So we hope you guys can tune in. We'll also record it and put it on our website if none of those times work for you. So just be on the lookout. There's a PCMH-specific webinar in July, a HealthLink-specific webinar in August, and then a webinar specifically about well child visits and how to succeed with those EPSDT visits in September. All right, so the next announcement has to do with regional collaboratives. So many of you have participated in these. What it looks like, it's a 2-hour meeting. It's kind of similar to this conference, but it's a shorter time frame, and it's even more regional. So we'll have one in Nashville, we'll have one in Murfreesboro. You can go to whichever one is most convenient for you, and you can send whoever from your office makes the most sense. It looks like August 21st will be the one in Nashville, and right here at the DoubleTree, August 22nd will be the one in Murfreesboro. And the topic is going to be community resources and how to incorporate them into your practice transformation strategy. So how to use those community resources to really bolster the support that you give to your patients. We will be sending out some more information about how to RSVP for those. We just wanted to get the dates in front of you now so you can mark your calendars. All right, and we're already preparing for our next round of conferences. So today we're at the June conference, and the next set of these is in October. So October 24th, we'll be getting you guys all back together for a similar day like today with more updates and more learning opportunities. So October 24th will be the next time, and we hope you can make it out again that day. All right, so now I want to make sure that we all know who each other are in the room. There's lots of groups here and associations and organizations, so I'm going to call out your organizations, and if you can just raise your hand and let us know you're here. That way, if you want to meet with another group, or if you've been, trying to meet somebody, you can know where they're sitting, and I encourage you to introduce each other and mix it up. All right, so we'll start with our health plans are here. So we have some folks from AmeriGroup here. All right, we have some folks from Blue Cross, Blue Care here. Great. We have some folks from United here. All right. Also, we have State of Tennessee folks here. Great. We have Q-Source is here. Saw Jennifer, yep. And the Tennessee chapter of the American Academy of Pediatrics, TNAP. Great. Okay, and we have Brentwood Pediatrics. All right, Camelot Care. Great. Capstone Pediatrics. Okay, Centerstone. Comprehensive Medical Care. Cookville Pediatrics. All right, Covenant Care. All right. Erlanger. Fast Pace Medical. Okay. Goodlettsville Pediatrics. All right. Health Force Corporation. Okay. Healthy Kids. All right. Life Care and Omni. Matthew Walker. Meharry Medical Group. Mental Health Cooperative. Mercy Community Healthcare. Great. Neighborhood Health. Man, I feel like we have perfect attendance today. This is great. Pediatric Associates of Davidson County, right? Putnam County Peds. All right, Quality Matters. St. Thomas Medical Partners. Okay. Tennessee Pediatric and Adolescence Center. Terrace Pediatric Group. Okay. Tullahoma Pediatrics. All right. Almost done. Unity. Okay. And Volunteer Behavioral Health. Great. Did I miss anybody? Okay. Well, I really do appreciate you guys all coming out from clearly near and far to be here today, and we hope that we make the most of your time. The next section, we're going to talk to you more about the care coordination tool for a little bit. So I'll turn it over to Brooks Daverman, who is Director of Strategic Planning.
All right, good morning, everybody. That's great. Thanks, Carly, and thanks all of you for being here. Just talking to some of you, it's great to get to kind of hear your stories. Everybody here is really committed to helping your patients to stay healthy, coming up with new ways to do that, and that's the whole reason we're all here together. So anyway, it's just great to be in this room. All right, so we're going to talk about the care coordination tool a little bit. Let's see. So this is just the agenda. We're going to kind of talk through some of the achievements, give you an update, and some idea of where we're going with the care coordination tool. And we do have some facts to go through about the care coordination tool. We have a care coordination tool roadmap and an update on the rolling calendar survey. So achievements to date, and I want to back up a little bit more. When we were just thinking about the patient-centered medical home and the Tennessee Health Link, we brought in groups of stakeholders to help us figure out how to design that, including, I think, the leadership from many of the organizations here today. And we realized just how important it was going to be to get this kind of information into your hands, especially to know when your patients are in the hospital or the emergency room in real time, and a lot of other things that you all know that the care coordination tool can do. And it's been a long road. For those of you who were here at the beginning of our programs, you'll remember care coordination tool wasn't really even there yet. It was kind of a couple months before it got started. But now we still have things to work on, but we are so far along the path. And I'm really proud. I think my whole team's really proud that there are capabilities there that you just can't get in other states. And so other states are really interested in what we're doing. There's some states that are already also doing this or moving down the path. But even with the things that we still have to work on, we are really a leader right now. So let's celebrate some of the achievements, some of the milestones. Just to have this tool statewide, data from 3 different payers, right? One place you can go for all the managed care organizations, hundreds of thousands of TennCare members, and all in the tool. We did have some problems early on with the accuracy of member attribution. I think some of you probably remember that, and I think that we've cleaned that up. I mean, we don't see that problem anymore. Of course, with anything on this list, if you do still have something you want to let us know about, please do. But it's great that attribution is now, it's updated every week, and it is accurate from our testing. We also heard feedback from you to add the Social Security number so that you could more easily match the members to your own electronic medical record. So we heard that from you. We made that change. Just last month, we've made major improvements. So claims level detail, which was being masked, is now available. You can see it. Let's see, what else do we have here? The training. Sorry. So the training. So Dylan and Debbie, they already, you'll see more of them, but we get really good feedback on the training, and we encourage you to take advantage of that. We're also proud that you all can now document shared notes about members, and that can be shared between a HealthLink and a PCMH. And then the ADT, I really started with that. We have now 70% of hospitals sending in their data. Okay. Feeds from the remaining hospitals. So, 70 is good. We want to get to all the hospitals sending in their data. And so we actually just sent out an email to everyone that we had an email address for at these hospitals that have not yet sent it in. A lot of them are working on it. We also let them know that there's going to be some changes, some repercussions in terms of taking away some of their funding by September 1st if they don't get that data sent in. So, we all got a lot to do. We want to just raise that priority level a little bit. I think for those of you who are in regions where your hospital's not yet sending it in, I feel like September is a pretty good chance that you will be seeing that from the remaining hospitals. So we're working with them, and everybody's working in good faith, but we're hoping to just kind of tie things up on that. And then continuous improvement. So in addition to getting the rest of the ADT, we do want to continue to improve. We know we continue to have some issues that we need to address. We're going to continue the training on site and through webinars. So, if you haven't started working with Dylan or Debbie, you still have time to do that. We are also going to do more to communicate by email when there's a known issue, when we fixed an issue, so that you kind of know what you're seeing is not, you're not the first person to see that. We're aware of it as well. I think that'll be very helpful to you all. And we're also going to establish ways to do more quality assurance, so to check the information that's coming out of the care coordination tool. A lot of the things that we have found and fixed or are working on were through you all reporting it, and we really appreciate that you have done that, and some of you have done a lot of that, so we really appreciate that. But we also want to be able to catch things on our own, so we're going to work to have more of that. And let's see if I missed anything. We'll just continue to review your feedback. You can email us at hcfa.spig care coordination tool, spigcct@tn.gov. We really do want to hear from you, and that email address is the best way to do it. So I'm going to turn it over now to Dylan to go over the next couple slides.
But thank you all for being here. I'm going to probably bounce around a lot, so if you have any questions, let me know. We're going to spend the next little bit talking about some things that the CCT can do, some newer functions. Brooke just touched on a couple of them. We're going to take a quick look into some of this. I want to make a quick mention that where you see the balloons, that's where Debbie and I will be hanging out. So during the networking break or during lunch, if you have an interest in coming up and seeing our training schedule for the rest of June and for July, come and see us. We're happy to talk to you about what might work for your schedule and how that process goes. We also have a session in the first portion of the breakout session this afternoon. So from 1 to 2-ish, we'll be in the room around the corner. Look for that. Many of you have already signed up. We'll be going through some of this information in more detail, pulling up the tool and actually clicking around in it. So if you have any questions about what you're seeing here today and you didn't sign up for that session, feel free to come. We're expecting it to be a little cozy. It's a smaller room, and we did have a good number of people sign up. So just want to let you know. But do come. We're happy to have everyone come. And with that, let's talk about the CCT. Okay, so a couple things. As Debbie and I have been on the road, we've heard from some people like, these questions, like I wonder if the CCT can. Well, have you ever wondered something like, which option should I use to look at my data in the CCT? Many of you are probably familiar with the old default option. It defaulted to 2019, but you had to change the measure version year to 2018, and that occurred on multiple screens. Well, that's now been addressed, and the appropriate thing for you to do, if you've ever wondered which one should I use, is to use 2019. So the default option in the tool should now automatically pull up to 2019 if you're on something like the Quality Measures tab, or if you're looking at a particular member summary page and you're looking at some of their guiding opportunities, or even if you're on the dashboard, it should default to 2019. And that's what you want to use. The tool's been reconfigured so that the 2019 HEDIS measures are now applied to your 2018 data, and so that's going to give you the most up-to-date view of your performance as well as how your members are doing in terms of their open gaps. So keep looking for 2019. It's always confusing. I'm still looking for like a good explanation of why HEDIS organizes it that way. It's like, I guess it's like the Super Bowl almost, to do all of your stuff this year and then the payoff is next. I don't know. It's a terrible analogy. I'm going to take it out on its own. Okay. So next up, have you ever wondered something like coordinating care in general would sure be sweeter if I had a good view of claims data for all my members, particularly claims data that's associated or that's not been filed by my organization, came from somewhere else, specialty, urgent care, hospital, whatever it may be. Well, Brooks mentioned this just a moment ago, and the good news is that the CCT now has that level of detail for you guys. It's going to provide you with information that touches on the visit type, and that touches on the service dates, the provider name or the organization name, CPT codes, as well as ICD-10 codes. And you're going to be able to view all of that under the member summary page, which looks like this. There are two options to kind of get there. This is actually clicking down on the member summary page. You click on the health tab on the left, and then you look for visits. You can also look for the little, it it's hard to see, but in the kind of bottom left corner, there's like a little settings gear icon that I think we're all used to seeing on web browsers these days. That appears next to each member's name on multiple pages. So like my members page or quality measures page, each line item is going to have that little gear symbol. And what you can do is you can click on that to view the member summary. It's going to open up in a new window. There are benefits to doing it both ways, and that's something we'll look at specifically in our session this afternoon if you have any questions. Okay, so claims data. It's awesome, particularly again if the claim came from someone outside your organization, specialty organization, urgent care, the hospital environment, something like that. Okay, next. Have you ever wondered, it would sure be helpful if I could share notes. Save a note about a member and have that note be visible to someone else in my organization. Also, as Brooks mentioned, this is a new function within the CCT, and we're happy to report that it's now available for you. So, as Brooks mentioned, if you have patients who are in both THL and PCMH program, and you coordinate with your counterpart, you can save a note for a particular member, and it will be visible to that person's other care provider. Additionally, if you're an organization that has multiple sites and your member typically goes to site A, but sometimes to site B based on homework, whatever it might be, then you can also save a note and have it be visible to members within your organization, regardless of whether they're at site A or site B. And so that continuity of care and care coordination will go to you through the notes view. All right. Have you ever wondered, is there a common identifier, a common indicator that I can use to search for a member between my system and the CCT? The Social Security number is often a good place to start with that, but sometimes your system might only show the last 4 numbers, or sometimes I think we've seen, maybe your system doesn't have a Social Security number, or whatever it may be, but there's another way you can do it as well. So who here in their system has access or keeps track of a member's TennCare ID? I'll just two? Oh, I don't believe them. There's the third one. All right, now that's more like it.
Because I look those numbers up when I have to text somebody, so it is there.
It is there. Awesome. Great. And how many of you have seen in the CCT something called an altruista ID? Same 3 people. That's awesome. Well, the good news is that those 2 numbers are actually the same. So if you've ever searched for a member by last name and then had to do first name as well, and then had to do birthday, and then you want to quadruple check, and so you're looking at Social Security number, and then you even have questions. Also consider the altruista ID versus the TennCare ID. Places where we've seen this to be particularly helpful are if you're trying to compare member lists. So it's not just that I want to necessarily find a member in my system versus find a member in the CCT, but if you are trying to isolate new sets of members by pulling your member panel from the CCT, and then you want to know, okay, who was recently attributed to my organization? Well, you can pull that list from the CCT. You can pull your list of members from your system, and then you can use something like the altruista ID and the TennCare member ID as a unique identifier to isolate duplicate values, and then identify unique values. Those would be like your new members. To do something like that. That cross comparison analysis is made much more effective and efficient with something like this. Okay. So have you ever wondered, I think I need to reset my password. I don't remember what it is. Can I do that? And the answer is yes, you can. So like with most good and functioning and custom service friendly websites, the CCT has a forgot your password link on the homepage. And this is what it looks like. It's right there underneath the password box. So that is something you can do yourself. And that would be certainly anytime you forgot your password, it's happened to me multiple times. sometimes multiple times in the day. Altruist loves me when I call and I'm like, hey guys, so forgot my password again. But there is a link for you to do that, take care of that on your own. Okay. Speaking of Altruist at the support desk, they have a wonderful support desk team that is available to you. There's an email address, there's a phone number, and they are there to help you. But what are the types of things that you might want to contact the help desk about? So there are a few things that we typically see, and there are things like password resets. So if you tried the link, something isn't working, you can't remember your username as well, whatever complication there may be, you can call Altruist or send them a note, and they'll help you reset your password. They can help you with navigation in the tool. Where was that button that I saw that one time? Give them a call. They can help you find it. Additionally, if you have staff members on your role or your roster who have had roles within the CCT or user profiles, and you need to inactivate them because they've left your organization, the Altruist support desk can help you with that as well. And then they can also help you with technical issues. And this is like that big, technical issues is kind of like that in other duties as assigned sort of job description on most hiring posts. It's like, oh, I'm going to spend 20% of my time doing something that's like other duties. Well, technical issues kind of falls into that category. And what we simply mean here is that outside of navigation in the issue, outside of navigating the tool, outside of finding a particular data point that you're looking for, if you're looking at something, if you're looking at a quality measure and you think one of your numbers is low, or if you think there's information that's missing from the claims field, or if you see something like that and you just want to talk to somebody and try to figure it out, or the CCT is showing that a gap for a member is open, but you've checked your claims data, you checked your service dates, you understand there's a little bit of a lag time in the CCT, you think you're well within all of those parameters, and it's still showing open, but you think it should be closed. Those are the types of technical issues you can also call Altruist with. The thing to keep in mind when you're talking to them with regard to a technical issue on those levels is that examples help so much. So if you've gone through the steps of going back through your claims history and you've seen that a claim has been paid, you know that the service date was 6-8 weeks ago, and you really do think that gap should be closed, give them a call, jot down that Altruist ID, jot down the date of service, jot down the date at which your claim was paid, and then pick up the phone, give them a call. They'll be able to really work with you on that front, and hopefully resolve your issue very quickly. So, information always helps. If you've got it, give them a call. They can help you resolve that. And with that, I'll turn it over to Georgette. So thank you all. Again, you can find us at the Balloons if you want to schedule sessions in the coming months. Thank you guys.
All right. Thanks, John. All right, well, I wanted to wrap up the CCT segment of the conference with a couple of slides here. This first one here is our roadmap. So things that we are trying to work on, trying to make happen for you in the care coordination tool. And of course, a lot of the information that we're presenting in the slide is feedback we've heard directly from you. So we really appreciate, those recommendations that we get, and keep them coming. So the first thing that we have on here is improved quality assurance for the gaps in care data. This was something that Brooks had mentioned earlier. We really want, we are this is our top priority right now. This is our top priority as well as Altruista's. So we're working on getting this data available to you in the care coordination tool and making sure it's as accurate as possible. We also want to implement a process for you all to more easily identify who your new members are from week to week. So as you know, the member panel lists are refreshed every week. So each Monday, your list may look a little different, but for the most part, they're the same. So we want to be able to have you guys more easily identify who those new members are from week to week. And then the last thing that we have on here is to include prescribing provider information with the medication data, claims-based data that we have in the tool. We've heard from a lot of you guys that prescribing provider information would be really helpful. You can already see pharmacy data, so where the prescriptions for your members are being filled and dispensed, but we would really like to include prescribing provider information for you as well. So we will keep you posted. All right, and lastly, I wanted to provide a brief update on the Care Coordination Tool's rolling calendar. So you may recall from the last set of conferences that we presented some information about the rolling calendar in the Care Coordination Tool and how that accounts for some of the differences you may see in the data that you see in the tool compared to the data that you see in your MCO quarterly reports. So we ended up doing a survey online back in March, sometime around there, to really get a sense of where you guys stand with that rolling calendar. We heard that it sometimes presents some challenges when addressing gaps in care. And what we found was really a mixed bag of preferences for the rolling calendar versus a standard traditional calendar year. And so with that in mind, keeping the Care Coordination Tool on a rolling calendar, we wanted to explain how it works and what it does. And so we created an FAQ document about it, and part of that is what you see on the screen here today. So the Care Coordination Tool has this rolling calendar. What does that really mean? Instead of looking at a traditional January 1st to December 31st calendar year to identify gaps in care, it uses today's date as an anchor date to review claims data and then populate that gap in care status. And so we also wanted to point out some of the benefits and how this works. Instead of seeing every gap in care for every single one of your members at the beginning of the year, January 1st, you're going to see those gaps in care populate in the appropriate time interval. So for example, if a child regularly has their well child visits in June every year, then the CCT will populate that as a gap in care in June rather than January 1st. And so we have some more specific details and specific examples of how this works in a handout on your table. It is titled the FAQ Rolling Calendar and 2018-2019 Dropdowns. So please take a look at those. They were also sent out to you via email. Share them with your colleagues, and if you have any questions, let us know about it. All right. Checking the time. Do we have some time for questions? 5 minutes? All right. Any questions from anyone here about the information we presented? Nobody has questions? Yes.
I was looking on the CCT, and I had patients that say maybe they're 3 years old, and they were 0 compliant. And it showed that they needed every shot that you would need up to 3 years of age. And when we go on tennis and look, they're up to date on shots. So where?
So, yeah, no, that's a good question. And the immunizations data is a little bit tricky. So that information from tennis is not interfacing with the Care Coordination Tool. So you won't necessarily see that up-to-date claims data that you would see in tennis in the CCT in regards to immunizations.
So, but I mean, so how would that happen? Maybe a child comes from out of state, maybe, and gets on TennCare, and so that way they don't have their data, or so it didn't come through on claim stat. How does that happen? And it shows that they don't have any.
So it's that they're eligible for certain measures based on like the criteria and things that are laid out in I think it's the childhood immunization status HEDIS quality measure. But if there are specific examples that we can maybe touch base on, I think that would be helpful. I'll reach out to you. Mm-hmm. Any other questions? No? Okay. Well, with that in mind, I think there's a break coming up. If you guys do have any questions and didn't want to share in the group, just feel free to come up to me today or email us anytime. There are several of us here, so feel free to reach out to us.
All right, this next session, we're very excited to have our guest speaker with us, Dr. Michelle Buckner. She is a board-certified pediatrician. She's the Chief Medical Officer of Community Care of North Carolina. She's also a physician, executive, and leader with a diverse clinical and administrative experience in academic, FQHCs, and hospital and managed care environments. And she's accomplished in developing practice facilitation programs and supporting quality improvement efforts to support population health. Please welcome Dr. Michelle Buckner.
Good morning, everyone. Good morning. I am really excited to be here today and share with you all around care coordination models, something that's near and dear to my heart. I am absolutely passionate as a pediatrician, especially about coordinating care for children, but definitely whole populations and families. And so to be able to share information with you today is truly a pleasure for me. So today we're going to go over care coordination, why it's important, why we should strategically, and that's the important message today, manage our populations. We can't manage everyone. And so, although we would love to, we have to use our limited resources wisely. What are the potential staffing solutions? So I know many of you are probably doing care coordination, and through my clinical experience, I know what a challenge it is, having worked with many practices. So I'm here from North Carolina by way of Kansas City for about 20 years, yes. So I've been in North Carolina about 2 years, and I was raised in Maryland and did my medical training in Maryland, so I've kind of made the loop. But through all of those experiences, realize what a challenge it can be, especially now as we've converted, not are converting, but have converted to value-based care on top of the fee-for-service services that we provide. Also, looking a little bit about what tools, and you heard great information about the CCT tool, can't say that 3 times fast, that you have here in the state. And I will agree with your speakers that you have a unique resource. So in North Carolina, and I'll tell you a little bit about CCNC, we do not have managed care yet. Actually, I practiced in Kansas where we had a mayor group and United, so I'm very familiar with friends from those associations. Administratively, I did managed care work in Missouri, so familiar with that. Tools are really, really critical and crucial now, and we'll talk a little about the data needs that you have. But having one resource that you can go to with the 3 managed care companies is really something that you should take advantage of. And they did not pay me for that plug. So right now, so when I moved to North Carolina, I was recruited away from Kansas, closer to the ocean where I wanted to be the chief medical officer of a 5-site FQHC. And through that experience, learned a lot about adult care, about social determinants, and how to attach those in that whole person model. And so that is what care coordination is about for me. So I'll share more about that. Right now, and I have a pop-up. So this happened yesterday. Christina, it says restart required. I'm not going to touch anything. So Community Care of North Carolina is the longest standing medical home organization in the country, and I actually was exposed to them through my PCMH work in Kansas City, became aware of them long before I was even thinking about moving to North Carolina, so it's very cool for me to be a part of the organization now. in probably 2007, before NCQA even had a medical home model, I heard about this model that was being developed and fell in love with it. The only thing I felt like I could tackle then was referrals. I thought the idea of tracking referrals was so cool and so new. And then became project lead for our hospital-based clinic for our NCQA 2008 recognition process. So I've done it as boots on the ground. I love it. And then through that, developed the PCMH facilitation model for our children's hospital, working with primary care practices. So with that, I do want to know a little bit about who's in the room. So I heard a lot of pediatrics. So who here is from a pediatric office? Yay, thank you. And then family medicine. Is there family medicine in the room? Behavioral health. Oh, wow, cool. And then, because FQHCs are now near and dear to my heart, anyone from a FQHC? Yes. And that kind of brings it all together for me. So for community care, we provide care coordination, care management services for the entire Medicaid population of the state. And that's built on a primary care base. So we provide those wraparound services to help primary care practices manage their population. But the next level you'll see on top of that foundation is data. We are very data driven. We take that claims data, and while we know EHR data is there and very useful at the practice level, having claims data is really cool. Having ADT feeds is something that a practice you often don't have. So having that data is something that we also encourage the practices to utilize. And then having the practices understand a population health strategy. And we provide a tool through our practices or reports to our practices that are dashboards, so they understand what their population looks like. And so that helps you strategically manage those populations. And all of this is done with a multidisciplinary approach. So we have pharmacy engaged, we have behavioral health engaged, then our care managers. We have physicians as subject matter experts, but we do not provide that direct care. Everything we do supports the providers that provide the care to the patients. So when we talk about the rationale for care coordination, when I first started in practice, it wasn't really on the radar, but we have seen certainly over the past 20 years a shift in what we're required to do. And a part of that shift has made a requirement come to the forefront for care coordination. So having team-based care and knowing what that team looks like and having efficient workflows with that team, the challenge of patient access and scheduling. My story around that is that when we actually employed a care coordinator at the FQHC, most of her time, unfortunately, was trying to find access for people coming out of the ED or people coming out of the hospital. And that wasn't what we wanted, but because of the access and scheduling issues and challenges, that became a prime role for her. We also are looking at data collection and how we utilize data. We are looking at challenges with coding issues. If you're using claims-based information, you have to make sure you're coding correctly so that information populates where it needs to populate. Chronic disease management is huge right now. When I went into pediatrics, part of the attraction to me wasn't the kids and the hugs, but also that this was a healthy population. And so I felt, well, I can keep them healthy till they're 18, and then what adult medicine does with them, I can't answer for. But right now, we are, as pediatricians, facing almost the same level of chronic disease in our populations and the children that adults have now. So one strategy that I like to look at is really three components when you're doing population health. Making sure you have a good team. So a team that's absolutely patient-centered. If you don't have that, you can have all of your components in place and you won't be successful. You have to know how to engage patients. Being organized and being well-coordinated, and that's where the care coordination comes in. Utilizing data. is part of your QI strategy. So understanding your populations and then risk stratification, which will be on slides soon. And then building sustainability into your model. That, part of my journey was about 6 years ago, I went back to get my MBA because I realized to do population health and to really be able to impact the underserved population, that I needed to understand business. And so people will ask, how do we as providers understand the need for this, but how do you get administration to understand? And that's, you've got to be able to speak the money, and you have to build it into your sustainability model. And so focusing on the value and focusing on where your incentives are to create these efficient and effective systems. So when we did practice facilitation, my learned lesson is that often we started with team. And I learned a process through Qualis that talks about practice transformation from the standpoint of change concepts. So I don't have a slide because that's part of a little bit of homework I'd like to assign you. If you're not familiar with the Qualis Safety Net Medical Home Initiative materials, it's worth taking a look. And what they did was implement practice transformation through the NCQA model in safety net medical homes. And through that, they decided that the best way to do this is through these change concepts. The change concepts are tied. There's a nice crosswalk to PCMH. Definitely to 08 and to 11 and to 14. Can't speak to 17 because it didn't peak. But I did the training, and so I think it's all applicable and ties in. So with that process, the first stage is laying that foundation, and that, of course, is the most important. And the two components of that for them, one is leadership. So if you don't have leadership engagement, your house is going to crumble. And then having a very good quality improvement strategy. So it's very difficult to implement these changes if you don't have a QI strategy. The next level is building relationships. So that's getting your team in place, but also empanelment. So the patients have to be tied to a team, and you have to have a team for the patients to be tied to. The next step is organized evidence-based care, and that's having a system in place where you have your disease management models in place and you have patient-centeredness. The last layer actually is reducing barriers to care. And the two barriers that you're trying to reduce is access to care, so that's about enhanced access, but care coordination. So the reason I bring this up is because care coordination can be, but doesn't have to be, the toughest challenge of getting in place. And I would say that you don't have a perfect structure. Part of my residency training was the enemy of good is better. It doesn't have to be best. It doesn't have to be perfect. But you got to think a little bit about leadership and QI. You don't have to wait and build all of these steps, but they should be in place when you're talking about adding care coordination, because that's something that can be very frustrating, and you want folks to feel like you're making positive changes. So as we talk about care coordination, there's probably about 50 different definitions out there. AHRQ did a study that looked at it and tried to define it. We're talking today really about care that's coordinated across the healthcare system and the patient's community. So we're talking about, the medical neighborhood, but also community. And community, I think everyone in this room would agree, is really important. So you have your patient, but then you have their internal community of family. You want to make sure you engage them, and then the broader community, and then we're going to talk healthcare. The purpose is just to reduce fragmentation. The healthcare system, especially when you have chronic diseases, can be extremely challenging. And so having a system in place to support patients through these, I know, as I support family members through care, I don't know how people that don't have medical training or healthcare exposure make it. And so part of our approach is we really need to support them in navigating through these systems. And it includes referral management, but often systems have a separate, more automated process for that, and then linking the patient to community resources. I think you all are probably familiar with the definitions that are here in Tennessee. The PCMH definition around tracking tests and referrals and transitions, really important. That's probably the biggest gap that we can help bridge for patients is transitions from the ED, transitions between providers, transition from hospital to home. And then HealthLink has I would say, a more broad definition that actually ties back with the PCP. So I mentioned a little bit earlier about the drivers for the need for care coordination. The top two, prevalence of disease and multiple systems of care, are really patient-facing drivers. So we are seeing, and the next slide shows that, a higher prevalence of chronic disease. So many people, and I know in my FQHC experience, most patients had 3 or more chronic diseases with behavioral health on top of it. And so when you have one chronic disease managing 2 or 3 specialists, if you have diabetes and you're seeing maybe a nephrologist and an ophthalmologist, that's tough enough. And then you're trying to get back to primary care. But if you have diabetes and hypertension, go ahead and add in cardiology. So for a patient, coordinating that care from a primary care perspective can be a challenge if you multiply it by the number of patients you have. So having a great system in place, or a good system, sorry about that, is really important. So the multiple systems of care and the fact that we don't communicate well can be definite challenges for patients. And then on the provider side, or the clinical side, we now are quality and outcome focused. So it used to be good enough to make sure your immunizations were up to date and to make sure you did a A1C, all those process measures. But now we're moving into outcome measures. And so that really takes a team, and it's a big lift, but having that team in place can help facilitate that lift. And tied to that are changes in payment, and that's what I was speaking to earlier. The reimbursement is now becoming, or is somewhat tied to value-based care, and so that tie of the payments to the outcomes is where you can demonstrate a need if that is a place where your organization is finding a challenge to your administration. Find out where the incentives are, find out how you can achieve those with the staff you need to achieve them. So as far as the chronic disease burden, the statistics now are really overwhelming, and these are a little dated, so we can add to this, but about half of all adult Americans have at least one chronic condition. 1 in 4 Americans have at least 2 or more. 7 of the 10 causes of death in 2014 were from chronic diseases. And so this speaks to the need to have these care coordination processes in place. If you start to add behavioral health into that, so individuals with behavioral and health and physical health care needs actually account for a large percentage of the costs. And so as we look at where lack of care coordination is and how we risk stratify, looking at behavioral health needs is going to be really important. So you can look at this slide one of 2 ways. You can look at it as the glass half empty with, when you have uncoordinated care, and this was an interesting study done by the Institute of Medicine that looked at identifiers for uncoordinated care. So multiple primary care docs involved, multiple pharmacies filling prescriptions, multiple ED visits. And if you look at the uncoordinated care costs versus the coordinated care costs, that's your business case. But the flip side of it is look what coordinated care does. Look at how it decreases those costs. So if we start to look at population health and how do we look at risk stratification, you can look at several different levels, and many of you may be familiar with this population health pyramid. So what we do at CCNC is really around that most intense population. I think over half of the folks we care manage, and we have an impactability score that helps us determine the population. Most of them also have a strong behavioral health component, and then maybe a social determinant. And so the next level is the complex illnesses. So these are folks with multiple chronic diseases and other issues. And then the mild to moderate are people that may have one or two chronic diseases, but they're actually well managed. So typically the most intense is your top 1 to 2% of your population. The next level is 3 to 5% of the population. And then 50% is the mild to moderate. And then everybody that's not on this is your healthy, well folks. So I mentioned a little bit about social determinants. What's really interesting now in North Carolina is in the next 15 to 18 months, we will have managed care in our state. Legislation has been passed. We're awaiting a waiver. And social determinant screening will be required by our prepaid health plans. And that is really exciting for me. Again, as a pediatrician, social determinants have long been on our radar as we look at the family unit and what the challenges are for the children in those families. So I would suggest that as you look at risk stratification and you're trying to figure out where can we focus, you can't necessarily look at all the social determinants. There are nice screening tools out there. Health Leads has a beautiful tool. The FQHC's developed something called Prepare. So you can choose questions. It's nice to use validated questions, I will say that, because then you know you're getting to what you want. So the state of North Carolina actually chose questions from different tools, from Prepare, from the Hunger Vital Sign, from HARC, for interpersonal violence. And so looked at core domains that we will look at, but I would suggest that that's possible within your practices too. So if you decide, okay, we're going to focus on diabetes, looking at access to healthy food options and where you have food deserts or food swamps. I think we're sitting in the middle of one now as I drove in here, lots of fast food around. That's going to impact the patient's outcomes. And so while this can seem overwhelming and daunting, if you have a strategy where you can focus your efforts, at least with baby steps, it's one step at a time, it's, the how do you eat an elephant one bite at a time, however you want to look at it, dive in somewhere and then expand from there. So social determinants, not a surprise probably to the folks in this room, definitely impact the state of health within Tennessee. Tennessee ranks 37th in the risk of child homelessness. And I got distracted because I'm thinking about Texas. That's just bugging me, and that's just putting it mildly, sorry. To afford a rental home, it takes 85 hours a week. At minimum wage. 17% of households are food insecure. And then really striking, 61% of adults have had at least one adverse child experience. And so as you're looking to outcomes, while we focus on chronic diseases, it's really important to think about social determinants because that's part of your patient engagement. And that's a way to engage. That's what's important to people, food and shelter. And so if you can engage them on those, and as we actually implemented the Prepare tool and used a medical assistant, community health worker combo to do that. And the way in which they could engage patients as part of our team, I shared with them openly, I felt had potentially more impact on somebody's health than I ever could. I can give you prescriptions all day long, but if you don't have transportation to fill them, then I've basically done little for you. And so I would encourage you to at least take a jump into that too. We know that your population health needs are always going to outweigh your system resources. So this is where, bringing your heart and brain together of how do we use our infrastructure and how do we use data analytics to actually address the impact. And so identifying who you need to impact. And that's where having an organized system to collect some of this information is important. how do you influence your practices, whatever level you're working at, and in whatever kind of environment? You know, you are the champions. You're in the room today. That tells me you are the ones that are carrying the message back. And so it's really important to share this with your coworkers of, you know, we need to promote this change within our system. How do you implement this? And then finally, improving it. So I'm really excited to see that CCT tool. I'm really data-driven, and mainly because it helps develop your strategy. So how do you take your huge population, and it's not about who's in front of you, right? You have panels and folks that you're working with, and use your limited resources to target your intervention. And then being able to identify from your tools, whether it's in your EHR, I don't know, I apologize, how many tools you have. It depends on, you know, if you're predominantly Medicaid or if you also have commercial payers. And if you have Medicare, you're probably looking at your STAR metrics. And that's where you get a matrix together and you figure out where is the biggest return on investment for our practice. We want to do everything for everybody, but we also want to keep our doors open and we want to pay our staff. And so who should you touch most strategically will help devise what your system should look like. So as you collect your EHR structured data and look at your complex conditions, you want to tease out who is poorly controlled. And then I mentioned the possibility of adding on, if you're doing depression screening, if you're depressed and have diabetes, and there is a higher rate of depression within the diabetic population, it's unlikely that you're going to be very adherent to your medication regimen or you're going to be eating properly. And then layering on high cost and high utilization. So who's overutilizing the ED, and we know while EDs are necessary, you're not going to get the best care for your chronic condition there. And then lastly, overlaying that social determinant. So if you look at your whole population, and I just introduced these layers as an idea, I would challenge you to look at your practice and what your layers should look like as you're determining your population health strategy. So we're going to look a little bit at the staffing models, and I want to mention that after I speak, we're going to have a really valuable opportunity for you all to get together and share your experiences, because peer-to-peer learning, I'm a strong believer in. I love group medical visits. I love learning and learning collaboratives, and I didn't start there. I had to learn it through experience. But there's a lot of value that comes to the practice. So it's not just value to the patients. Care coordination can help you reinforce your evidence-based practices, can definitely help you with performance improvement, quality improvement, making sure that your EHRs are properly populated, your problem lists. If you're looking at RAF scoring, often they can assist with that. Your plan visits, and then helping to develop that collaborative care plan. So if you look at your medical neighborhood, care coordination actually is the bridge across everything. So your community resources, your medical neighborhood, and your multidisciplinary support, your QI system within your own practice, and then supporting the care team or being part of the care team that all surrounds the patient to achieve outcomes. And so here in Tennessee, you have health link administrators and your PCMH directors. Often practices may have a lead clinical coordinator. Care managers, care coordinators, I'm using the term interchangeably. You may have health educators, and if you're lucky, you may have a community health worker. And so this is all about folks working to the top of their license and making sure that you have the right people in the right functions. Now, depending on the size of your practice, this may be one person, and that's fine, just as long as the roles and responsibilities are clearly defined. There's also the opportunity and we'll talk a little more later, but my experience with community health workers was that in Kansas City, there was a community-wide initiative to create a program of training for community health workers that was in a community college. And while we as systems, and again, I was part of a large children's hospital, were trying to get our act together, the church did it. I mean, they just got community health workers in the community, and that's who we could rely on to do that work. So it doesn't have to be just in your practice. It can be folks outside of your practice that are doing this work. It's about communication and coordination. So you really have to have, I'm strong on the idea of a good foundation. And so having that care team structure and knowing what that communication is going to look like is probably the most key and critical areas. Making sure that your job descriptions are aligned, and often that isn't the case. I've been in, I haven't been in that many organizations, but I've been exposed as I've done PCMH facilitation work, that often what people do is not really aligned with their job descriptions. And so part of the first step or second step is you're looking at your relationships and defining your team is clearly defining what is the role of the care coordinator, what is the role of the staff nurse. Making sure that there's some quality assurance in place, and then making sure that you're managing the right size panel. We can only manage but so much with the staff we have. So if we look at the key functions, some of which I've mentioned before, the care coordinators link to community resources. And for me, this is a big part of the value because we often, as clinicians and clinical staff, team members, operate within the confines of our walls. The care coordinators, that opportunity to partner with community resources, especially around social determinants, or even just resources to support their needs. If they have pharmaceutical issues, and I'm stepping a little bit into the uninsured world, but if they need resources to even just support what you are trying to do on the medical side of things, the care coordinator can help with that. Helping to manage referral protocols. That doesn't mean actually managing referrals, but the protocols associated with your process. Establishing protocols for chronic disease. Proactively tracking and supporting patients. And this is a clearly strategically defined population we're talking about based on what your system looks like. Patient communication, care management services, and again, I use that term loosely, not in the case management well-defined definition. And then, as I mentioned, transitional care is where you have a huge opportunity. On your table is, and there's a question for, so don't look now. I know, resist the urge. Are these competencies? And so you'll have the opportunity to dialogue about what is the most challenging and which ones you find to be key competencies. And so being able to develop partnerships, not manage. These are folks that have to create partnerships, being able to communicate, actually developing care plans and doing assessments and tying them to goals. So 3 models that I can share today. One is using your existing staff structure. For most, I think this is the most attractive model because we're using our existing team members and folks that know us, know our practice, somewhat know the patients, and they spread the tasks across the team. So care coordination doesn't mean you have to have a care coordinator. You just have to take care of these functions. So depending on your staffing model, that'll determine how this looks. But the other option is to have a dedicated staff member that is a care coordinator. And so when NCQA PCMH first rolled out, and then other folks also created models, there was a look back at, did this cost more or did it cost less? And so as I was first doing, of course, I was hopeful it was going to cost less and I could show my system, if we really reduce costs. Unfortunately, it actually costs more, and that could be a challenge for practices. But the reason the cost was there was the additional staff member as a care coordinator. That was one consistent theme through PCMH implementation that occurred. It was challenging to use your existing staff to do this model of care. And now remember, this was early in PCMH, and so a lot of the data wasn't available, a lot of the systems, the EHR structure wasn't necessarily there. You had to create your own disease management registries. So it's possible now, and we're seeing more folks kind of spread it amongst the team or add the additional care coordinator. The other possibility is working with someone like our organization of CCNC. And so we have care managers in networks throughout the state, and we serve that purpose. So we take referrals or we identify the patients, and then we also have embedded care managers that go and work within the offices. And so finding external resources, whether it be your friends at the managed care organizations or within hospitals to coordinate the care, is another possibility where you aren't utilizing the resources. And certainly when you look at ACOs developing, they are incentivized to reduce their costs. When I was at Children's Mercy in Kansas City, we were incentivized because we were full risk and capitated. So we were also doing the same sort of care management and embedding care managers. Often care managers are RNs, and really because they have that ability to do education and have those critical thinking skills, often within primary care are the ideal team members to be care coordinators. But that doesn't mean that they hold the duty alone. So it can be a team RN that's just coordinating the activities of your clinical team and delegating. So, doing the follow-up phone calls and doing managing the referrals, just making sure that you are fully doing the closed loop cycle of referral tracking can be delegated out. Then you can have true case management. When I was at the FQHC, we were in an ACO and we received grant funding, again, to actually hire an RN case manager. I was lucky one of our staff nurses had been a case manager and was a certified case manager, so we utilized her services there. And then using that centralized care management approach. So if you're part of a hospital system or a larger system where you may refer some of those duties out, what I find to be most valuable is definitely having someone that wears that care coordination hat embedded in your clinical teams. Having someone remotely, that communication tends to be a little fragmented, and so having somebody there that participates in your daily workflow can be ideal. And so I touched a little bit on the community health workers that can do outreach, they can connect with patients. These are folks that often should be, not always, are from the community of the patients that we serve. And so they can connect with patients and get patients through your doors and help implement your intervention. So they're part of your extended team. Want to make sure we focus on the whole person care, so connecting your physical, your mental, behavioral, emotional, and social all together. In working with the array of providers should be the focus of our care coordination processes. And so many of you are probably familiar with this graphic that shows a way to start to also stratify who you're working with from a behavioral health perspective if you're looking at integrated behavioral health. And so the y-axis is behavioral health needs from low to high, physical health needs on the y-axis. And so if you look at quadrant 1, these are folks that you probably don't need to support much except for through your routine PCMH processes. Low physical health and low behavioral health. The physical health needs, high physical health needs with low behavioral health are probably best care coordinated from the standpoint of your physical health home. Someone with high behavioral health needs but low physical health needs are probably best coordinated care from your behavioral health perspective. And then when you get to quadrant 4, where you have high physical health and high behavioral health, probably that 1% of the population, this is where we have to communicate and we have to work together to be able to provide the best services for the patients. So as we look at the high behavioral health, high physical health, complexity, and risk, those are folks that are typically served both by specialty behavioral health and primary care. And unfortunately, I don't know if Tennessee is been able to resolve the issue of communication between behavioral health and physical health. We have such a challenge of systems talking that what we're working, I also work at a county level as a medical director, and I think for us, we have found that the person-to-person communication is going to be ideal. You know, going back to old school, we can't fax, we can't release records, we can let you into your system, but you can't go into our system. If we just, it's a small population, get back to that person-to-person communication, that's going to serve these patients really well. So as we look at the visit, and hopefully you all are organized for patient visits in the pre-visit, the post-visit, and between-visit model. And so the way to look at this model is to start to think of where does coordination of care touch each phase of this, and that's how you can start to define the duties of the care manager. So do they participate in your huddles? Definitely they are, during the visit, should have an opportunity to come meet with the patient. Coordinating that is really important. Closing the loop, and then between visit is probably where they have the biggest value because we often don't have the resources for that. So telephone calls and emails, or having some health coaching occurring if they're doing an every 3-month visit, or even between the a 2-week visit. What is really challenging for patients is to hear what we say as providers while they're in the room. If they have a family member with them, they tend to absorb more. But having that post-follow-up call to make sure they understood what we said, just like doing teach-back right after the fact, doing teach-back a day or 2 later is really important. What stuck? And that's where care coordination can help. So as we look at a typical day, and there is no typical day, so I apologize for using that term, but we do try to have some structure for our day-to-day visits. And so typically your PCP and your care team is going to look at the schedule, do some pre-visit planning, have a huddle, have your morning clinic, have some opportunity, you know, definitely not on a daily basis, but to look at your trends and gaps and be engaged in the population health management model that you have. And then hopefully you have some opportunity to have staff meetings, and then you'll have an afternoon clinic. Well, how does that look from a care coordination standpoint? They should also be reviewing the schedule, looking at where there's opportunity to engage with patients they're working with, participating in the pre-visit planning, bringing forward what issues have occurred during the gap from the time that the clinic team has seen that patient. That's really tends to be critical, crucial information. And it can be an efficiency measure. So if you already know before you walk in the room what's happened, they've been to the hospital, they had challenges with the prescription, this is part of your return on investment. This is an efficiency effectiveness measure. Attending the huddle, meeting with patients, reviewing the analytics, and then participating in the afternoon clinic. So if you look at the care management cycle, it's identifying through risk stratification who your patients are, having some sort of assessment, what are the patient's needs, how do you intervene in that patient's care, developing a plan for that, monitoring their progress, so that's the ongoing care coordination. The goal is to transition people out of care coordination needs. That's the goal. And so empowering the patients, educating them with self-management support so that you reduce their risk and so you can provide services to other folks. It doesn't mean you stop monitoring them, but you just have lower touch with them. And so if you look at, and you do have these slides, what it looks like for a low-risk patient, it still may be of risk, but you can't, you don't have the resources to manage them and everyone else that you're trying to manage, then it's touches like automated messaging and doing some outreach phone calls, having them have access to your portal, having well-organized clinic visits that address gaps in care, and then doing reminder calls as necessary. Now, the higher risk patients are the ones that have those transitions of care, and those are the ones that's really important. Those are the high cost, the high utilization, the ones that you're going to have poorer outcomes for. Those are the ones that are worth investing the resources, because that's the most impactable population. And so knowing when they have been admitted and reviewing the plans of care there, making sure you're doing med rec, that's one of the, we have a really robust pharmacy program because of the challenges with medication errors and med adherence for patients. Proactively reviewing, like I mentioned before, after a PCP visit, what the plan of care is. So if with any program you want to have some sort of measurement process, and when you're establishing this, you want to decide what is the purpose of our measurement. Are we doing it for quality improvements? Are we watching our A1Cs? Are we doing it for accountability? Do we want to make sure that that your process is working, and it's not about people performance, it's about system performance and process improvement? Or are we doing it to evaluate the quality of our care coordination? So with that, I'm going to open the floor for questions. I will be going around to the tables, and so if you have questions during that time, I want to invite you to ask me then. And then this is my contact information. So, do we have any questions? I don't know names, or else I would call on people. So, the nice young practice manager lady that I met this morning, she's going to kill me. What was your name? Yes, see, I started off right. Patty? Yes, so Patty is relatively new to primary care, and we were talking a little bit about her challenges. So are you doing care coordination in your office?
Yes, so, oh, no.
Thank you, Patty. I owe you.
So care coordination has been challenging for us because we had a nurse practitioner start recently who would really walk into this role naturally. But so we've really struggled with who would we identify as our care coordinator. But we have challenged each physician's designated nurse to track that and keep up with that. But I don't know if that's correct.
And yeah.
Because you really need that one person, I think, to track it.
And I would say I think that's a good way to start in. So when I first did PCMH, I had joined a group that had been in practice 20 years. And, being pediatrics, the message I heard when I said, hey, there's this cool medical home thing, and I want to do it. And our chair said, we've been doing medical home for years. And so as pediatricians, so I didn't get a lot of support. So I was lucky to have consultant support that was grant funded, but I started with my nurse. I mean, we just did a team and we developed the process. So that's the baby step. I think having, this big system in place can be a challenge. So I think you're starting the right way.
And I don't want to hog the microphone.
Uh-oh.
But
I created a monster.
The three things I wrote down that we really focus on care coordinating is the chronic patients, our referrals, and the ED visits. Mm-hmm. That's really kind of our three focuses right now.
Yeah, and I think that's pretty typical. So the transitions you hit, the chronic diseases, and then what was your third? Referrals, yeah, so having referral tracking, I think that is typical. Yeah, so how do you decide in the chronic disease, and if anybody else wants to share their mic, how do you decide in chronic diseases? Does someone have a really good system for doing that? How do you risk stratify? How do you decide who you're going to work with if you have care coordination? Maybe a behavioral health provider. I know you guys are in the middle here. Yes.
I think that's a difficult question because in the behavioral health field, social determinant is huge. I think the social determinant is a huge factor for us. More than enough times we have the level 4s that you mentioned, the 1% of the population is practically all of our population. And so, trying to get them to whittle down each little thing, that's chronic, that is affecting them, plus where we're located in Cookville, we have a huge, it might as well be the Mojave Desert because they're just all over the place. And so trying to get them primary health care, trying to track gaps, and trying to keep up with all of that stuff to satisfy the Tennessee Health thing, it's really difficult to do. And so we try to, Dave Ramsey has a good policy of a snowball effect. He starts with the lowest one first and then kind of work your way up. And that's what we try to do. We try to knock out the thing we can do. We'll take care of that first, and then we'll move our way up and take care of the next thing after that.
Yeah, so I think that's a good, so you guys know what he's talking about with Dave Ramsey. So the approach to reducing your debt, which I love, the application of that model. What we did as the FQHC is actually sat down, and so that's what I mentioned, with our local psychiatric. So UNC has a psychiatric facility, and they have assessment there, and they actually have primary care embedded into that system, but they manage the more severe and persistent mentally ill. And so we as the FQHC developed a referral process so we could refer into their clinic, but also so they could refer into ours. So it's a matter of who's best, if you were 3 or 2 in that model, who's best to manage the patient.
We're kind of sort of doing that. I mean, we work with JoJo over at Cookville Pediatrics, but it's just that talking to each other, being able to know what was treated here as opposed to what was treated here. There was a time where the care coordination tool, each of us were supposed to be able to access that, and we could read what the other, behavioral health is working on as opposed to physical health, and working those things together. I don't think we got that yet.
Notes function. Have you ever wondered, can I share notes from one provider to the other? It's called the activity record. There's a notes function, and you can now do that. So it's up and running.
So raise your hand who he's talking about partnering with. Oh, he's partnering with you. Okay, so now you guys tomorrow can start messaging to each other. And I would say for other people in the room, find out who your partners are and how you can start to communicate, because, the data systems aren't going to give you that level of detail that's really probably most impactful in a patient care. So thank you for talking to each other. Yeah.
And I was just going to mention, too, Constance Payne, formerly with HealthLink, now at the Office of eHealth, who actually helps run the tool, the care coordination tool. So I just wanted to remind you that there is, we use CDPS, which is a risk stratification tool, and those scores are in the care coordination tool. So yes, that information has to be predicated on the receipt of the claims. So it won't necessarily take into account social determinants, but it will give you a good starting off point. You can see critical, high, medium, and low risk score. So you can, that should also be able to kind of help you determine if someone's in a critical state. They likely have multiple chronic disease states, probably also along with social determinants. So that can kind of give you a good way to decide how you kind of want to tackle different groups, who you want to focus on, who you need to focus on, and that's all built into the tool. And if you have any questions about how to use that feature, Debbie and Dylan can help you out, figure out how to integrate that into your workflow, and that's also a good option for everyone.
Yes, I would really take advantage of those tools. That's unique to have that opportunity, and you can definitely realize that improvement in outcomes. I would say to that point is, you may not, what was mentioned, you may not want to tackle that highest risk patient first. You may want to, check off the low-hanging fruit and things where you can connect folks and hand off some of that work. That'll reduce your burden.
Precisely, because it's overwhelming. If they look at all of that as one big, elephant. Yeah, they don't even know where to begin. To whittle that away.
So I would say for those that are just starting on this, or I know I had several false starts. You try and you just try different ways. So, taking that easiest level of patient to manage first may be a great first step. So I think we are at time.
We have about time for one more question.
One more question?
If there is one.
Okay. So, Rick, are you coming back or? So we are going to ask you, please don't move first, to break up into 3 groups. I felt like peds was more over here, so if the pediatric folks can move to this side of the room, behavioral health is already here. You guys nicely segmented yourselves. And then adult medicine, family medicine over here to go through the questions on the table and share. This is where you can learn from each other. There's lots of knowledge in the room to assist you in developing your models.
And this is similar to the Success of Organizations session that we did, when was that, March or April? Whenever we had the last conference, I don't remember when it was, but where you broke up and you got with other organizations to talk about these things. So split your groups up, get with folks from different practices. If you're an MCO, if you're TenCare, if you're a coach, intermingle with these groups. And again, we have our family medicine over here, our behavioral health in the middle, and pediatrics on this side. And then we're going to come together about 11:40, 11:45, and have you brief us on what you've discussed. All right, everybody. Now it's time to share with the larger group some of the discussion you've had, and let us know where you're at and where you're going in regards to what we've talked about with care coordination. So I do know names, so I can call on folks, but I'd like to have some volunteers that would like to talk about. You don't have to go through the whole list of things, but pick 1 or 2 that you've had some discussion about, where you're at and where you're going. Now give us about 10 seconds of awkward silence, and then I'm pointing fingers.
Yeah, I'm ready.
Yeah, and Dr. Buckner's not afraid to do it either. So. Jeopardy music's playing in my head.
Are you willing, someone at that table, to share some lessons learned? Thank you. Good delegation, I like that.
All right, they made me do this, I'm just saying. What was the question?
It's a 5-letter word, Stephen, right there.
Well,
some people think that's a 4-letter word, but
so I'll just start at the top, I guess. So we talked about, we had really good discussion, by the way, at our table, and gained some insight here. So I think if I could just pass this around. So we talked about how our practice determines our patients for care coordination, and what we determined that most of us are doing are, as we pick those 3 primary conditions for our PCMH model, we're using that as kind of the launch, the benchmark, or the place that we launch this effort from, and then grow that into whatever we decide needs to be monitored a little more closely. setting up the care plans and the workflows around those care plans become, the model that we're using. And I think that for most of us, dealing with the pushback and trying to incorporate these workflows into the practice becomes the struggle. And dealing with the pushback often times pushes up to the provider level. And so what we determined basically was that if we can use our templates, that's the best model for trying to incorporate how we approach care coordination, and then having someone identified as moving through that process with our providers is helping us identifying those patients. We did have an interesting conversation about Aunt Bertha here at the table. So we were talking about resources, community resources, and I had never heard of this, but apparently there is a website called auntbertha.com, which lists a lot of local resources by zip code. So news to me, share that with everybody. Maybe it's news to someone else. Aunt, A-U-N-T, Bertha, B-E-R-T-H-A.com, auntbertha.com. So I was surprised. Thanks for that tidbit. And Amanda Bain apparently led that effort. So we also talked about the health department being one of the primary resources for us locally, and having a lot of TennCare patients, we do push a lot of our patients to the health department for additional resources that they may need, and apparently now Aunt Bertha is going to help out. I can go on, but I'll let somebody else share.
I do. I have one question for you, and then I'm going to ask our AAP representative to share more about the health department, because I'm not from the state, and I think that's a really critical resource. But can you talk more about your barriers and the pushback that you're getting in implementing these changes?
So the barriers really come into play for the clinics that I work with specifically in how you determine how you're going to document, and more specifically, having to bring those patients in on a more often timeline. So, when we identify those conditions, set them up on an every 3-month follow-up, there's your pushback. And having to do a care plan at each visit, those kinds of things then really impact those workflows and really cause the pain points that you have to work through. To the point, in some cases, where we changed what we're following because it just became burdensome for the clinic to keep up with, and our providers to keep up with. And so looking at those communications across the organization and trying to figure out, well, how do we adapt because this isn't working? And obviously in PCMH, that is the process, identifying those pain points and doing something different. And so that's.
And I think what you're speaking to, that adaptability is really important. Oh my goodness, I don't know where I'm going. But apparently she thinks I'm going somewhere right now. I'm heading south. But when you translate this a little bit to business, one of the things that folks are really talking about is how to become really agile and how to be scalable. And so what you're talking about with that adaptability is, although you're creating these structures, you've got to be agile and flexible, because people are going to be changing those carrots continuously. And so you have to figure out what works. So I appreciate the fact that you've capitalized maybe on that flexibility.
And I think it's something that as you implement PCMH, it becomes a learning process for the whole team. Change is going to continue in the practice, and that's the hard part of delivering that message, that it isn't just a one and done, ever.
It's continuous. So you embrace change. The only constant is change. That's our favorite saying. Thank you so much. So who wants to share, maybe from the middle of the room? Our behavioral health teams. Thank you, sir.
So one of the barriers that we talked about was the cross-communication between providers, going from behavioral health to PCP and getting PCP on board with THL and getting them to work with us. Personally, in my experience, these smaller PCPs have been the more difficult ones. Those attached to larger organizations like Tenova, Vanderbilt, St. Thomas, whatever it may be, they've been on board or easily came on board from the beginning, where the smaller independent PCPs fight us on everything. I mean, whether it's us being there for a visit to us feeling, hey, TenCare said we need to have these metrics met and to meet this gap for the client. Can you please make sure that they get put in billing this way so everyone gets their stars, everyone's happy, and I walk out the door and that paperwork gets file 13 and, they don't care what I had to say or why I was there. And so definitely, we would, as a case manager being there in the field, I would like to see that bridge come together better so, make it easier for my clients. So that was one of the things. Thanks.
Well, and I think that, wherever you are in the country, that's one of the critical pieces where this table shared that often it's patients don't want their PCPs notified, and so that sort of cultural barrier that may exist and the stigma that still is attached to addressing behavioral health conditions. But also, our state, North Carolina, has laws that are in our way for communication. And so that's where we as systems, and I guess if I get to challenge the state a little bit, because that's our challenge that we're taking on in North Carolina, is how do we as a system bridge those gaps? If you're incentivize us to work as a team. So that's what you're saying. We all want to get our stars. We all want to work together. How do we message within primary care and the independent practices to achieve those goals? And that, I think, is on the systems to create change. It's hard to do that one-on-one because you've tried. You realize that. So to me, that's a systems level concern. So where's TenCare and folks like Rick? Sorry, they're not going to invite me back now. Go ahead. I tend to get on a soapbox eventually.
But this is a great venue for you as well, because you have PCPs here that they're a step ahead of those other folks. So wherever your location is, and definitely find out where these folks are and reach out to them. So what city are you in? Lebanon. So what PCPs are in Lebanon?
Got one over here.
Kathy, so if you're not working with Capstone, right there's. Okay. And then find out where else. So, this is an opportunity. This is one of those things that we try to make happen for you as well, is to have those communication conversations here. And then when we have our regional collaboratives, whatever the topic may be, feel free to talk to each other about other things as well, because that's part of the reason that we create those for you as well, because you've given us information that you want to discuss these things, but take those opportunities to make those connections and build those relationships. And then eventually some way we can get those non-participating PCPs into the fold as well. So, but thank you for sharing that.